So, my dancing crew isn't working out, so we're going to study acute kidney injuries. So AKIs or acute kidney injuries, these used to be called acute renal failure. I'm out of breath from that dance move. We got rid of that term because we didn't want patients to think that their kidneys were failing, because in reality, AKIs are very, very reversible. So the features of an AKI is a rapid onset. When I say rapid, I mean minutes to weeks. So this is probably something that's happening more inpatient. You're monitoring your patient's urine output with their Foley catheter, and you notice, oh no, this patient produced like no urine for a couple hours. Or if you picture someone in a nursing home, maybe you have an old lady and the aides notice, okay, she hasn't peed for a couple of days, like she definitely has an AKI. Really different situations you can have this. So like I said, rapid onset, minutes to weeks, oliguria, and increased BUN and or creatinine. So when we have AKIs, we can divide them into pre-renal, intrarenal, and there's actually post-renal, but we're not talking about that today. So focus on the pre and intrarenal. So pre-renal is the most common. There's other kinds, but today, like I said, we're going to focus on pre-renal azotemia. And azotemia simply means an increase in nitrogenous products, BUN or creatinine. And then intrarenal is acute tubular necrosis. So what you do to figure out if this is pre-renal or intrarenal is if the BUN and or creatinine is out of range, that's when you calculate a BUN over creatinine. If it's greater than 20, then that is indicative of pre-renal azotemia. And if it's less than 20, that's indicative of intrarenal azotemia. So with pre-renal azotemia, you're going to have decreased perfusion to the kidneys. Basically, this just means that you're not getting the perfusion, the vasculature that you need. And then the labs for this, like I said, BUN over creatinine greater than 20. So FeNA, that's fraction of excreted sodium. That's basically the calculation of how much of sodium that's filtered through the glomerulus actually ends up in the urine. So with pre-renal azotemia, it's less than 1%. The way I remember this is that you have decreased perfusion, so you're trying to keep all the sodium. You're not having enough water, so you're holding on to all the sodium in hopes of pulling water with it, so not very much sodium ends up in your urine. And then specific gravity, the rate, higher the number, the more concentrated, greater than 1.015, which is a little bit concentrated, is associated with pre-renal. So once again, you're not, you have decreased perfusion, so you have less urine output. It's more concentrated urine. And then the urine sodium is also pretty low, less than 20. So moving from pre-renal azotemia, which is just decreased perfusion, think of it as kind of like dehydration, dehydrated kidneys, to intrarenal is acute tubular necrosis. So with acute tubular necrosis, you know that we have our tubules and the epithelial cells are just dying off. So just remember that, death of tubular cells. And then the BUN over creatinine is less than 20. The fraction of excreted sodium is greater than 3%. So this one you have a little bit of more sodium going into your urine because your tubule cells are sick. They can't hold on to the sodium. And then our specific gravity is lower in this one. We can't hold on to sodium, we can't hold on to water, so the urine is a little bit more dilute. And then the urine sodium is greater than 40. So with acute tubular necrosis, just remember we're not really holding on to sodium or water very well, right? And then the treatment for any AKI is to exclude extruction. So that would be like if you have benign prostatic hyperplasia in males, that would cause a urinary obstruction, which might back up to the kidneys and cause AKI. Treat the underlying cause, whatever it may be, and then discharge all lines. So if your patient has a Foley, IVs, a PICC line, pull them all out. We want to get rid of this infection if there is one. So the recovery time for an AKI, this can be 1 to 12 weeks. I think it's like a third of patients progress to chronic kidney disease if they have an AKI, but like I said, it's very reversible. So to conclude, AKI, we have pre-renal azotemia and acute tubular necrosis. Make sure you know these labs really well. The main one, fraction of excreted sodium, is less than 1% for pre-renal and greater than 3% for ATM. Thank you.